So you're all very welcome this afternoon to our Sláintecare webinar. I'm Gráinne Healy and I'm delighted that you've joined us for today's session. This Sláintecare webinar is the 23rd in our series, and we are delighted to be delivering it in partnership with the HSE. As always, we're very happy to take questions or comments from you, the viewers. Just use the chat function and I will convey your remarks or questions to the panel of guests with us this afternoon. Sláintecare is about the right care in the right place at the right time by the right team. We're focusing today on a project called the Linn project, which is delivering an enhanced primary care service for children and young people in Galway City North and West. Primary care services for children and young people can sometimes be hard to navigate for families, especially where a child may need to access a number of different services. Families may find that there's a separate referral for each service, as well as a separate postal address linked to the referrals, and even a variety of referral forms in use. The Linn project is looking to change that with a single point of entry and a strong focus on early intervention and prevention. The Linn project is looking to adopt a no door is the wrong door approach to the provision of health and social care in our community. So I'm delighted to be joined first up this afternoon by Catherine Flynn. And Catherine is the Community Health Network Manager, and she's the project lead for the Linn project. Catherine's going to speak to us about the background to the project before we then meet the rest of the team delivering this really interesting project in Galway City North and West. Catherine, you're very welcome. Thank you so much for joining us this afternoon. So Catherine, would you kick off and tell us maybe what is the problem that your project set out to solve?
So first of all, thank you very much for inviting us here this afternoon to talk about our project. And Gráinne, I think you have outlined really, part of the problem we're trying to solve, in that traditionally children's services in primary care, they tend to operate in a unidisciplinary way, meaning, as you referenced, that children are referred to various disciplines at various times. They can be sitting on many waiting lists, and families receive lots of appointments. Families tell us that they're telling their story over and over again. And I suppose what we're seeing is that this service can come across as fragmented and difficult to navigate. And I suppose what we're seeing now is an increase in the number of children being referred to primary care who have needs across a range of services. And this, I suppose, has, come into focus much more recently with the rollout of progressing disability services for children and young people and the establishment of the Children's Disability Network teams. So I suppose what we're seeing is that children who maybe in the past attended disability services are now being referred to primary care, and indeed, we would acknowledge that their needs can be met in primary care, but they definitely require a more multidisciplinary approach in order to meet their needs. So Sláintecare, I suppose, have funded us to test a model of delivering enhanced services for children and young people in primary care in a community healthcare network setting. And I'm just going to talk a little bit now about our community healthcare network and show you a slide that I suppose gives you some information about the community healthcare network we're talking about. So as you mentioned, Gráinne, our network is Galway City North and West. We have a population of over 61,000, and this reflects an increase since the 2016 census. We have a prediction that our population will continue to grow. We have a lot of inclusion health needs in our population. So, for example, we have 8 DESH schools, and DESH schools are schools tasked with delivering equality of opportunity in schools. We have a direct provision centre, we have a sizable traveller health population, and we have many international families. We also, unfortunately, have, I suppose, like elsewhere in the country, an increase in families experiencing homelessness. And I suppose another key factor for this project is that Galway University Hospital is located in our network, and indeed not only in our network but on our doorstep, and that will be discussed in a little bit by Dr. DC, but that has proved to be a wonderful enabler of integrated care. So suppose moving on, so in order to solve this problem, we received funding to establish a multidisciplinary team in primary care. So our Linn team consists of a consultant general paediatrician, an advanced nurse practitioner, 2 psychologists, a speech and language therapist, a social worker, an occupational therapist, and an assistant staff officer. Unfortunately, we've not been able to recruit a physiotherapist, and I want to highlight as well the tremendous support we have received from our colleagues in dietetics in order to roll out this project. So that is a little bit of background.
That's super.
And I suppose an explanation of the members of our team. Thank you.
Well done. That's really clear. Thank you so much for that, Catherine. So Catherine will rejoin us later on for the panel discussion. But to hear more about the project and the individuals involved in this multidisciplinary team, I'm delighted to be joined now by Dr. Deardra C. And Deardra is the consultant paediatrician with the Linn team. She's going to speak to us about the Linn project, the new ways of working and the impact on waiting times. You are very welcome, Deardra. Thank you so much for joining us this afternoon. As a consultant paediatrician, Deardra, what do you think are the significant elements of this innovative project?
Thank you, Grania. And thank you, Catherine, for the introduction there. I think, so as I'm the general paediatrician on the Linn team, and there's a number of things that I'm tasked with that I think are significant. And I suppose the first thing is bringing scheduled and ambulatory general paediatric care out of the acute hospital setting and into the community or primary care setting. So that's the main part of my role. And so Colette Goonan, our candidate ANP, and myself have set up and run a consultant-led integrated general paediatric clinic twice a week in our local health centre in Network 5, which is based in Chantala. And we're up and running for the last 5 months. And I suppose I'll talk a little bit more about the integration and what that means for our patients later. But the second element is being a member of the Linn team means that I work in this interdisciplinary team with my colleagues, and we have the opportunity for general paediatrics to address some of the complex medical and social needs of the children and their families within Network 5, within primary care, and address those needs, and that we can problem solve together and come up with a cohesive plan for these families. And this is particularly important for those families and children that may have difficulty accessing care and may be more marginalised. And then, so the third element would be that this opportunity to work as a team to develop kind of new ways of working and joint pathways, working with the dietitian and having joint dietetic clinics, and also working with new pathways with the occupational therapist. So there's kind of new ways of working within our team that we're developed and that are in progress.
That's great. Yeah. So, and I understand you're the very first community-based consultant paediatrician, and I think that's significant in terms of what is different about this project compared to the usual way of working. So you might talk to us a little bit about that.
Yeah, absolutely. And so this is the first publicly funded general paediatric post within the community, within primary care setting. And this allows, and the same for my ANP, for Colette Goonan, she is the first community-based general paediatric ANP. So it's a shift in trying to get the patient care and moving away from a model of acute services, which is where pediatrics typically were seen in the emergency department in the inpatient setting, but moving it back into primary care and integrating it. And so our clinic and our service is integrated both within the Linn team, but also within the wider primary primary care network by joining their meetings, linking in with the public health nurses, the area medical officers, with the GPs in the area, and collaborating and integrating that way. But also, as I also work in the acute hospital, in the hospital setting, we move seamlessly. Our patients move between our primary care clinics and into the emergency department, and then we link and into inpatient care, and then back out again. And so we can link patients quite quickly and seamlessly through the sections. And we also take referrals of patients from the emergency department who might have had frequent presentations or who need to see a paediatrician quite quickly, or patients that have no GPs, so that we can remove them out of the emergency department acute setting back into primary care and see a general paediatrician in the primary care setting. So it is quite novel, it is quite new. I suppose technology has been a real enabler there in terms of having a electronic health record within the Galway University's setting.
Yeah,
so that's been very helpful for us. But from a family perspective, it's been useful for them. Patients are often familiar with the local health centre. They've been here before, they've had a test done here, they've had their dental or their other screening done there. So it's a less intimidating setting for families and their patients to come. And so that's one of the things that we're able to do that's different here in terms of it's in the community. We can schedule appointments for, depending on the need that the family have, whether they need an interpreter or whether there's two siblings that need to be seen. And so we can, that's one of the things that we've set up here as well. And we support families really in navigating the system, and we support them in terms of having an A&P follow-up phone call afterwards that we can link in and make sure that the plan that we put in place is working, or what are the problems and what do we need to change.
Very good. So it sounds like we're really moving from what was a siloed approach to something that is much more through flowing for the patient and indeed for those providing the services. So the overall impact that it's having on services in the community and the hospital, is that a key one, the flow through?
Yeah, absolutely. And I think the rest of the team will talk a little bit about the other elements of the team and entering in. But from, I suppose, the impact within general pediatrics in Network 5, the waiting time to be seen by a pediatrician has reduced significantly from kind of a peak at about 17 months, now down to about 3 to 4 months for general pediatrics in our area. But this, by moving the patients out of the hospital setting, from taking from that waiting list in the hospital and bringing to our community setting, we've allowed more capacity within the hospital system. So there's been an overall reduction in the waiting time for pediatric services within the hospital setting, and the access is improved. So the time's gone from 26 weeks for semi-urgent patients to now 14 weeks. So that's a 46% reduction in the time for them to be seen within the hospital setting.
Yeah, that's very impressive indeed.
Yeah. And timely access is so important for patients and families, and getting the access within a more scheduled daytime setting as well. We had one patient, for example, that we were able to see in our clinic, get their investigations done, and then organise for them to have the emergency life-saving treatment that they needed. But we could coordinate that through the emergency department, through the daytime, linking with CHI for the specialised services that they need, getting the care provided in the hospital, and then we follow them back out in the community clinic. So that's how we're integrating through all the levels of paediatric care, and providing follow-up support for and addressing both the medical and the social needs that they have.
Fantastic. And I know when we were speaking earlier also, this was a model of work, a way of working that you had seen elsewhere, I think in the States. Could just tell us a little bit about discovering this model and wanting to replicate it and try it out?
Yeah, so my fellowship was in Vancouver in BC, and so they have a different model of care there in terms of they have very much acute services and community services. And after you've been seen in the acute hospital setting, you're discharged back to your community paediatrician and you follow up in the community there. So it's a very well established long-term system there. It's slightly different there in terms of they have a private and a public section and a private fee service to an element to that in Canada, which certainly is not what we have here. But it's exciting to have this opportunity, and I think this is something that every network would benefit from, having a general paediatrician that they can see, that can link with the wider team and support. So I think it's huge scope for this to be rolled out, and to have improved access for patients and families. And patients are really relieved, I'm sure, to be able to get that access.
Yeah, and the families, great relief, I'm sure, to get them seen in that shorter period of time. Tinta, that's a fantastic. I'm sure there'll be questions for you on the panel later on. So thank you very much for your time now, and we'll speak with you later. Just to
Thank
say to
you.
people, if you have any questions for Tinta or any of the guests, please do send them using the chat function, and I will put them later on to the panel when they rejoin us. I'm now joined by Dr. Deardra Cleary, and Deardra is the Senior Clinical Psychologist with the Linn Project, and she's going to talk to us a little bit about how Linn actually operates. Deardra, you're very welcome.
Thanks, Gráinne, and thanks for the opportunity to talk about how our team operates. So as you heard from Catherine earlier, we have a wide range of professionals who are all working together and collaboratively with the children and families that we see. Unfortunately, as Catherine said, we don't have access to a physiotherapist, but we do have pediatrics, social work, occupational therapy, psychology, speech and language, and then access to dietetics. So we're really lucky, I suppose, to have all professionals working together. We tend to take referrals through our paediatric colleagues, as Tinta outlined there, children who may have attended their clinics and that they wish to refer on to us. We also have monthly team meetings with our wider primary care service, where they identify children who may be on 2 or more waiting lists or need input from 2 or more disciplines in primary care and would benefit from a coordinated approach to their care. So I suppose that's how they come to us. Very often these children may have an additional layer of complexity based on family history. There may be family mental health issues, psychosocial needs. We also would see a lot of children who may have been considered for a local children's disability network team, but who didn't reach that threshold. I suppose a real feature that we're lucky at the moment in the early startup, we don't have a waiting list. So I suppose the benefits for families in terms of early access is it's great. You know, we're really lucky to be able to offer that. We also all work in the one location. We're here in Chantala Health Centre, again co-located with the hospital, which is just great. So I suppose what we will offer then, you know, in terms of seeing families for initial appointments, the team will offer at least 2 or more professionals will do that initial intake. And as Catherine said, it avoids families having to tell and retell stories, you know, which is what we often hear, that they may be on a waiting list for one service and then maybe a few months or even years later, they have to go and retell and start all over again. So I suppose the beauty being that we all work together, we do that initial intake, we share the information, we come together to kind of formulate with the family and gain an understanding of what the needs are. The family and their needs are very central to that. So it's very much goal focused, led by families' needs and wishes at that stage. So child and family led.
Very good.
Following on from that, I suppose we put a plan of care in place depending on which professionals are most needed. They'll go ahead and conduct their assessments, come back, we'll meet with the family and then agree on a plan of intervention. I suppose, again, as Tinta was saying, we do try to facilitate if maybe there are siblings involved with services. We try to meet both siblings at once just to evade duplication of appointments and time slots, knowing how busy families are. Similarly, we try to liaise with our local CDNT. So if they have children maybe attending both services, that we will convene meetings just to agree that we're all kind of working together. And again, that families aren't inundated with appointments or duplicate interventions.
Great.
So I suppose in some really a timely access to a team of professionals offering kind of holistic care and understanding of a child's and family's needs at a given point in time.
Great. Thank you, Deardra. And I know that there are questions coming in already, which I'll put you in the panel about criteria for referral, that kind of thing. So have a think about those and we'll get back to you. But that's really super. Thank you so much. We'll see you later on the panel. Thank you. I'm now joined by Dr. Noel Howard, and Dr. Howard is the GP lead with this initiative. Thank you for joining us this afternoon, Dr. Howard. Can you tell me about the collaboration that's happening between the community paediatrician or paediatric team and GPs?
So we've been lucky to have a fantastic collaboration between Tinta and the GPs in the network. As the GP lead, I've met with Tinta and Colette regularly since Tinta has taken up the post, and we've gone through what we felt the needs were as identified by GPs were with accessing paediatric services. And that's kind of informed how Tinta has engaged with us. She's come out to lots of GP CME meetings and the service has developed from there. We have kind of the formal referral pathways that would normally exist through HealthLink, and I suppose that IT referral system is very useful just to make sure that we can kind of follow the referral, make sure it's been received and get messages back. But we also have the informal collaborative kind of approaches by being able to contact Tinta over the phone or via email, and we found in other Sláintecare projects and initiatives that that informal contact is very useful and can often avoid the need for referrals. So sometimes the outpatient referrals have been historically for things that could be answered by a bit of advice from a specialist, or so I think that informal collaborative approach is very useful as well.
Great.
So I think we're working well together, and you mentioned siloed care earlier. I suppose the whole thing that we're trying to avoid is siloed. We're all seeing the same patients, and if we can see them in a collaborative way, that's going to be better for everybody.
For sure. And what are GPs saying to you about the service and the difference it's making for their patients?
I suppose first and foremost, they're really enthused to have a community paediatric service. Very encouraged by the wait list kind of reductions, because I suppose often in other services, the people that sit on wait lists are people we see over and over again with increasing worry and concern, and possibly deterioration of the condition that's needs attention. There's a kind of a perception of increased integration of care. So even though we don't have direct access through this project to the other professionals in the team, the feeling is that, there's an awareness that the pediatrics have access to the other professionals through the team. And so, these children who do have complex needs, who might need, other professionals and pediatrics, that integration is going to happen through this team. So I suppose the general feeling is better access for our patients, and better integrated care and less time waiting is very encouraging. So early days, but the feedback is excellent.
Yeah, and it sounds to me, the impact on the GPs themselves, seeing patients not watching deteriorating conditions, that kind of swift early intervention, that must be very heartening as professionals, being able to see that happening in this.
Yeah, I mean, there's two aspects to our work. A lot of the time it's clinical work, and then trying to navigate the pathways. So it was mentioned earlier that the pathways are difficult, and it's difficult to access care and to know where to access care. It's extremely difficult for us. So I can only imagine how hard it is for families. So this kind of envisaged single point of entry, I think, has to be the ultimate aim for us, because it would avoid duplication of referrals. It would avoid kind of unnecessary referrals, and the more streamlined the pathways, the better for the patients, the better for us, and the less time we have to spend trying to navigate what's the correct pathway. So we can concentrate more on the clinical work and liaise with the other teams as needs be. So I think that aim at the end of this project of trying to identify a kind of a single point of entry for these kids, who particularly the children who need more than one service, would be a great outcome.
Yeah, and at this point in the rollout, challenges, anything you see as we're learning about that?
There have been challenges as we've gone along in terms of IT infrastructure and teams. I suppose as was mentioned earlier, difficult to fully staff the team. So certainly a physiotherapist will be a great additional resource to the team. But so they'd be the main challenge. I think IT staffing and possibly how to directly access the members of the team as well as the pediatrics from us. But I understand at the minute that if we're referring to primary care and we were referring separately, that might add to duplication of referrals. So it's be better that it happens this way, at least initially. Yeah,
very good. And I think listening to you, some of those are kind of perennial problems across the health service, the recruitment, getting the right people in, holding on to them. But it does sound to me, Dr. Howard, that this is something that you're excited about and enthusiastic about, and that's great to hear. So thank you, and we'll see you on the panel. There are already questions coming in for people, so we'll put them to you when we get to the panel slot. Next up is Dr. Marian Lus, and Marian is the Senior Medical Officer and has close contact with all of her colleagues who are referring children and young people to the Linn project. Marian, you are very welcome. Thanks so much for joining us this afternoon. So this is not at all, it's still really great to be hearing about this project. Marian, we already have questions in, people saying, who can refer in? Who can refer in? So who can refer in is my first question to you.
So any member of the primary care team can refer to the Linn team. So that would include community medical doctors, such as myself. It would include psychologists, speech and language therapists, physiotherapists, dietitians, and physiotherapists. The main way that we refer to the Linn team is through our primary care team meetings, where we would discuss a child that has multiple needs in 2 or more areas. And that's quite a large proportion of children that we see in our developmental clinics, our second-tier clinics, as community medical doctors. As part of the National Healthy Childhood Programme, every child in Ireland undergoes health and developmental checks from birth until 5 years with their public health nurse. So these would be as a newborn at 3 months, 9 to 11 months, 21 to 24 months, and 46 to 48 months. And then if the public health nurse has concerns about 1 or 2 or more areas of their development, they refer on to ourselves. Now, sometimes it is a straightforward issue that we can kind of deal with just one referral, but often there is a need for that integrative wraparound care that really needs to be timely and all in one place, especially for the more vulnerable patients within the community, perhaps children where there could be a literacy or a language issue with the parents. So kind of multiple letters with multiple different addresses for them to go to. It's also an issue if the parents don't have transport. So definitely one place, timely access, just making things as clear as possible. And also having that timely access means that there's less kind of loss to follow up. Because sometimes if the parents receive their appointment with the speech therapist or the psychologist 9 months later or a year later, the issue may have kind of passed, or there may be a different issue at the forefront of the stage.
Exactly. Yeah, no, that's really interesting. And what kind of feedback are you getting from those who are referring people in?
So very, very positive feedback. I've spoken to a number of my colleagues who've also referred to the Linn team, other community medical doctors. They have received really positive feedback from directly from the parents who were just really happy and kind of surprised to be seen so quickly as well. And also just very positive feedback from those of us who have referred to pediatrics, to Dr. Tintadisi's clinic as well. One of the benefits is that we receive a very kind of comprehensive report on the child, whereas often when a child is referred by our service to hospital pediatrics, the letter goes directly to the GP. So often we don't receive a copy of that. Even though we've referred them, which is obviously disappointing. And the benefits of us having the letter is that we can file it in their paper child health record, and we have access to that, their public health nurse has access to that, and anyone else in the health centre who's dealing face-to-face with the child with the child health record has it. And that's transferred on as the child grows older as well.
Yeah, so useful. Again, this comes up a lot of parents saying, God, we have to tell this story to one more person. And it's not that, of course, they'll do anything to get their children help, but it's just the time saving. And as you say, being able to ascertain, have things improved or have they deteriorated? So having that file is really important. That's super, Marianne. And it does sound to me like, again, it's part of that flow through and streamlining that we're seeing with this project. So thanks very much for that. Finally, this afternoon, we're joined by Ora Kennedy, and Ora is the social worker with the team. And Ora is going to tell us about the impact on families and the feedback that as a social worker with the team, she is getting from families who have been referred to the service. Ora, thanks a million for joining us this afternoon.
Thank you, Grania.
As the social worker within the team, can you tell us a little bit about your role?
Yes, I can. Thank you, Grania. So I suppose the involvement of social work at a primary care pediatric level, it's very new. It's a very new approach, very exciting approach. It's in keeping with the goal of our team. I suppose that social work is about improving outcomes for children and their families through early intervention in an integrated and an inclusion health approach. I suppose this is done then collaboratively with my colleagues on the team and the wider primary care team. And as already alluded to today, this project is about improving health and social determinants for our community with the aim of improving the population's longitudinal health and well-being. Social work plays a unique role, particularly in this team, because it's very new to Ireland. In this regard, due to our focus on building relationships with communities, partnerships within community stakeholders and families alike. So over the past few months, myself and the team have been working on building a model of inclusion health and equitable service for all, for our harder to reach communities in Galway, City North and West, such as travellers, international protection applicants and other international communities in Galway. So we do have a very diverse and densely populated community, Grania. So we're working on the development of community initiatives such as parent and toddler groups, outreach clinics, and so on, because I think they are essential to the team. You know, and I think that this is very important given the current climate that the country is in, where people often commonly feel isolated and disenfranchised. So I think by forging and making those connections and synergies within the community, it'll hopefully help to alleviate some of these worries for families. So I believe that our team is perfectly positioned to meet these demands. And I'd like to share, actually, if I could, just a little test screen with testimonials from families that we've that it's been fed back to us in the last few months. So I'm just going to read from these. So I was waiting for services and contact for years, sitting on a waiting list and not knowing what was happening. But since you've become involved, it's been brilliant. I finally feel I'm getting somewhere and we are being listened to. I think it's great. Apologies. I think it's great how there is one team that they're all on the same page and are all working together. I don't have to repeat myself. I don't have to be coming in and out for appointments because you're all talking to one another. And that's in the same vein, I think, as what, you know, my colleagues were saying earlier. I just can't thank you enough for the team, for all you've done for our family. Thank you for all your help and support. And it just, there's a couple of other bits like that. Sorry. So there was a lovely one shared to us by Dr. Marian as well, just on the timely assessment and joint up kind of collaborative approach that the team afforded her family and her daughter. So that was lovely to hear as well. And we're hearing.
It's super to have the voice like that, you know, people being able to talk about the difference that it has made. And there was a common linkage there of getting seen quickly, people talking to each other, people knowing the story when they walk into the room. And that seems to be so important. And I know, I know from the work that you're doing, like having a social worker as a core to the team is so important. A lot of the communities you're dealing with, they have other social exclusion issues that may be contributing to some of the issues the children are experiencing. So your involvement gives you that key social eye, if you like, that perhaps would be missing without it. And I see that as an innovative part of this new model as well.
Yes,
very
I
good.
believe so. Thank you, Grania.
Thank you.
I'd also
I believe
like
you have one more.
Yeah,
you've one more share for
I'd
us.
like
Thank
to
you.
share just a parent experience that we were luckily able to capture, and I'd like to share that experience with you today.
Hi, my name is Geraldine. Before I met Orla and them, I was in and out of places trying to get support and help for my kids. I couldn't. No one believed me. Everyone. My child just went through absolute horror after horror. And then all of a sudden Orla and the team came along, and like that, my daughter's coming on in school. She's been more open because she's met them and they've made her feel welcome. They've made her feel normal. Before I met the team, I had days where I struggled and just cried all day because it was like no one was listening to me or my daughter. It was very frustrating and very hard for a mother to see her child suffer because of it. But now that Ava has met Orla, Emma, Aileen, and just so many that understand where she's coming from and don't put her down. If anything, they help her to progress. They have made such a change in her life and mine. Now Ava's back having hopes and dreams again because there's people out there that treat her normal. Like, you know, even in school she's improved, and that is all down to this service. Like, I don't know where I would be now if it wasn't for them. And I know a lot of other parents out there are struggling. But like that, I don't know, my anxiety, my depression, everything has improved as well since this team has come on. And I tell you, if other parents had the support that I have and Ava, it'd help a lot of families. And I tell you, there'd be a lot less of anxiety, depression, social, everything. You've helped so much.
I think it's very interesting having heard from the disparate members of the team. And in fact, they're not disparate at all because they're really working together in this approach. And what I'd like to do now is to ask the panelists to come back on. We have teams of questions coming in for you. You'd be delighted. So Orla, thank you. Many of the panelists today for the detailed picture of the project, and really great, I think, to hear from those families engaging with the project who are seeing already from a new approach that it is having a difference with them. So I want to invite back Catherine and Tinta and Deardra and Noel, Marianne and Orla. Thank you very much for staying with us. Deardra, can I come to you first? We've heard from some of the staff, but standing back from it, what, in your view, is the impact on staff working as part of the Linn team, and also staff working in the wider primary teams?
Thanks, Gráinne. I suppose having spoken to our own team here and also the wider primary care team members who refer to us, I suppose it's the boost to morale. I know staff can often feel that they own waiting lists sometimes because, you know, there's such a vast number of cases often waiting. So I think to feel that, you know, we can offer support, a step up service, maybe to families who are waiting, and to support staff and the wider primary care team has been huge, really, because nobody wants to see children waiting. So I suppose we're all very much of the same mindset and eager to support that. I suppose similarly, we've been able to offer a wider range of services that children both in our team and in the wider primary care team can access. I suppose we've had further access to training. We've more capacity to be innovative, to think about new ways of working. You know, as I say, then we also have the better interdisciplinary working, I think, across primary care as a result of this, because we much more coordinated in how we work with families at the moment. So I could probably go on, Gráinne, because we're getting, you know.
It sounds positive though, which is great.
Absolutely.
Yeah, that's super. Catherine, can I come back to you? At the outset, you explained about the problem that the project hopes to solve. Has the team solved it? Where are you at? I know you have a slide you want to share with us, but talk to us a little bit about, you know, progress made.
Yeah, thank you. So I think it's fair to say we've solved aspects of it. I suppose I'd like to highlight that although this project started in January of last year, January 2023, really recruitment took a lot longer than we expected. And we are, I think it's fair to say, just really towards the end of last year and start of this year, you know, in a position to really come together and start seeing children. So I think some of the things we have been able to do for this particular team, not, you know, we would like to solve it more widely within primary care, but we have been able to really reduce the number of referrals that families attend, the number of appointments, the files even, like, you know, usually each discipline has their own file. So now we have an integrated file. And you know, it's been referenced a lot. Parents feel that they're not telling their story over and over again. And in terms of waiting lists, I suppose the waiting list for various disciplines, like for speech and language therapy, it's 6 to 9 months. For OT, 12 to 16 months. Psychology, it's more than 12 months, particularly if it's not deemed, you know, a very high priority case. And as Tinta alluded to earlier, you know, the Gen Peds waiting list is also reduced. So that's just some examples of, you know, not being on those individual waiting lists, bringing it all together has definitely had an impact in terms of improved parent and family experience. And I think it's fair to say improved confidence in the service, better staff morale, and we've managed to solve some of the ICT issues for this project in terms of having access to the integrated patient management system evolve, and health links for GP referrals directly into Dr. C's clinic. So, you know, we've by no means you know, solved everything, but I think it demonstrates, you know, that there are, if you like, there is a way forward, and by embracing new ways of working. And I'd like to say, like, our wider team, because some of the questions coming in are around, you know, as well, the wider team, but this is very much kind of a team within a team. We're very, very linked to our wider primary care pediatric team. It's not a separate service. We've really tried to keep the boundaries very fluid and porous, and, you know, a very, very good in and out, you know, a flow through the team. So I think it's fair to say, you know, yes, to a degree, but, you know, we have definitely a way to go.
Okay. And tell me, are there plans to scale up or extend the project? I know this is a pilot. I know it'll be evaluated. So
so we're one of two pilots. Our sister project is the Linn project in Dublin. So we work very closely with our colleagues in Linn as well. And we've actually met with them very recently to look at, well, what's working well on both sites, because, you know, we're doing some things that are very similar and some things differently. So we're really trying to piece together, you know, ultimately what works well. So I suppose we're expecting an evaluation in the near future, and we don't know, I suppose, in terms of, you know, is this scalable? Is this something that will be rolled out more widely? At this point, we can't say yet. Predict that.
Okay, that's fine. So I'm just looking, there's questions coming in here. Deardra, somebody is asking, what criteria did the children have to meet to be referred to the team versus other services in primary care?
So I suppose that's very much, as Catherine said, that we work with our wider primary care team. So at baseline, I suppose it's that they have 2 or more needs, so that they've been referred into 2 or more disciplines within the wider primary care team. But then, as I mentioned earlier on, we have monthly referral meetings as well, which are attended by the Linn team, but also by the wider primary care team. And that's a huge support, I suppose, for all of us, that we come together, we discuss the children. Usually one of the clinicians will have seen the child at that stage, so we'll have a really good sense of what the needs are for this child and what the family's needs are. And as Catherine said, often the unidisciplinary is the way to go. So that forum, I suppose, provides a great way to figure out, are they, you know, best placed with the Linn team, or are they for the primary care team?
Yeah, and a linked question to that is, do you have children who are attending both primary care and the CDNT at the same time?
We don't know.
Okay.
I suppose what I mentioned earlier was really in relation to siblings. So if a sibling were attending CDNT and another to primary care, but no, we don't see both.
Okay. And one came in for Tinta there. Could the consultant pediatrician clarify how she works in conjunction with the multidisciplinary team? Would this model also work within the traditional primary care team rather than a separate team? Would it be more valuable to upskill and protect time within the existing primary care team model rather than establishing a new service? I mean, I think you answered this somewhat, saying it's not a separate team. This person is concerned about the prospect of another type of team being established and the possible dilution of those working out in primary care and indeed others. Tinta, do you want to just take that one? Because I think it speaks to concerns that people might have.
Yeah, absolutely. I'll try my best. There's a lot in that.
There is.
So I suppose for the general pediatric patients, a lot of patients that I would see would not require the additional members of the team. So a lot of patients would just come to see Colette and myself in our clinic, and we could make a plan and, you know, and discharge them or make a plan or review them back again, depending what their needs are. But for those patients that have more needs, and that we identify some complexity in whether it's a social work support they need, or whether they need occupational therapy or speech and language therapy, and they're just that little bit more. But this is a child that is probably functioning quite well in society and that does not meet criteria to go to CDNT level of care. So those ones are the ones that are particularly useful for us, and to kind of come together and discuss them and make a plan, and then the team can support me in directing where it's the best place for them to go to, and when and how we can see, and whether it's a quick intervention or a drop-in clinic service that we can provide for them, or a social work support, or what the next level or what the step is. So that gives us a cohesive plan that we can make. And I suppose the advantage of us being a team that works together in this is that there is not the 2-year waiting list and the time. So if I send an individual referral to all those people in primary care present, it could be 2 years by the time they've seen the speech and language therapist, by the psychologist, by the time they've had all the things needed. And so in that time, in those 2 years, they'll have come back to see me, they'll have seen Dr. Howard in his clinic, they'll have come frequently into us. Whereas by having this cohesive plan together, we can make a plan and get things started much quicker. And the beauty of that is by having this team and, in a way, extra resources.
Yeah. Okay. And somebody's asking, are you able to do autism diagnostic assessments within the Linn team?
So the answer to that is that question over, as that's not the general pediatrician part. Thank you.
I might come in there, Grania, if that's okay. So I suppose, as Catherine spoke earlier about progressing disabilities, autism assessment and diagnosis is starting to happen in primary care. We're really eager, I suppose, to join that, because we understand that for families to start their assessment process in primary care and to continue with the diagnostic piece would be ideal. So what we have started to do is work with the wider primary care team and access external supervision with the view to providing those diagnostic assessments. So they're starting. They're not happening in every case yet, but certainly it's about upskilling and developing competence and confidence for staff in the first instance. But it's definitely a work in progress.
Very good. And Orla, a couple of questions around your neck of the woods. People saying, just very positive comments coming in here. This is excellent. Love to see it rolled out throughout the country. And then specifically to Orla, could you comment on any parenting support and family support offered? Plus, is there an opportunity to provide targeted interventions for some of those marginalised and hard to reach families that you mentioned?
Sure, that's a great question there, Grania. It's very much a case by case, and it's family led and child led, needs led, for each individual family. I suppose some of the initiatives that we've undertaken at the moment are obviously directly in relation to our network in our area. So there's been some collaborative work done with the Galway Traveller Movement, with some direct provision centres doing some outreach work there, with my colleagues Dr. Tinta and Nurse Colette, and we're open to roll that out kind of in the coming months for more kind of targeted parental support for those harder to reach communities. For the general team then, we offer parenting course and Parenting Plus to Circle of Security as well, that we will hopefully be rolling out within the next couple of months as well. And that's all down to demand as well. So, it very much, we have the resources or the training here. We're very lucky on the team that we have a really wonderful team that is able to roll out and support parents in that manner. And just getting back to the more targeted, I think, did you mention?
Somebody asking about specifically targeted interventions for those marginalised and hard to reach families that you mentioned.
Yeah, so I hope I addressed some of that with, doing those outreach clinics in communities, and kind of forging, I think I'd alluded that to earlier in just my introduction. Making those connections with those partnerships and those community resources that are working directly with those communities, and working on building those relationships and going out directly to those communities. Yeah.
Very good. And another question that has come in, a comment, if you like, and someone might offer to take this. Somebody's saying, there are advantages to disciplines being unidisciplinary. And many of you have trained in unidisciplinary, so I don't think people would argue with that. they're saying here, you know, that there can be more autonomous, more focus on prioritizing therapy, and this may reduce meeting time and admin. So I think there's somebody putting it up to you here about, so you're multidisciplinary, what are the advantage of it compared to the uni? We've talked about the silos as one problem of unidisciplinary. Anyone else like to take that on, just in terms of your experience and how it's working?
Yeah,
No,
I'm
Catherine,
happy
yeah.
to. I'm happy
Thanks,
to.
Catherine.
I suppose I come from, my background is for many years speech and language therapy, and I was a speech and language therapy manager for a long time, and I totally agree. We have a lot of children in primary care who needs are best met and very well met by attending you know, a specific discipline. And indeed, you know, we sought feedback from parents recently enough, and the feedback in terms of their discipline specific services was extremely positive once they accessed the service. But I suppose we do recognize, and I think it's something that we're seeing increasingly, is children in primary care who have, you know, needs across a range of disciplines. And for some of those children, at a point in time, they might need a more team approach. And indeed, even our colleagues, you know, we will often have, for example, maybe a particular discipline saying, I can't go any further with this child until another discipline can get involved, because, you know, it could be, for example, a piece around, you know, behavior or around developmental coordination difficulty that's really, you know, making it difficult for that unidisciplinary, you know, clinician to continue. So, you know, I suppose what we're trying to develop is that at that point in time where you need the team, that you can access it, then you can absolutely move smoothly between a unidisciplinary and a more multidisciplinary model of care. But I totally would agree with that comment that, you know, we've been very successful in primary care for a very long time, you know, in terms of offering those unidisciplinary interventions.
Thanks, Catherine. That's a great answer. Shortran that has come in is excellent initiative. Can I ask how the dietitian pathway works?
So Tinta might answer that. Is that okay?
Is that okay, Tinta?
Yeah, absolutely. I can take that. So I suppose that we've just set that up in the last 2 months, and that's up and running, and we're seeing patients jointly. But for now, the patients are coming through the general pediatric clinic. So if they have been seen by me in the as for general pediatric outpatient, and lots of our patients would have an overlap. So if they see with me, then I link with Marian, our dietitian, and we'll see them either together if I need to follow up something, or some patients are new referrals that we'll see together at the same time for the first time. But primarily that service is through the general pediatrician. But obviously if the wider team have a patient who they have concerns, they'll refer them, I'll see them, and then I can link with the dietitian as well. But that's how it would work within the Linn team. But primary care have their own dietitian service that's ongoing, running their own unidisciplinary service. That's all going, that's not impacted by this, but we have through this project, there is extra time slots, so two dietitian slots per month.
Wow, very good. Okay, that's great. Thank you. Again, very positive comments coming in. This is an excellent initiative. I'd hope that it will be mainstreamed and rolled out in all networks. Congratulations to all the team. Very positive work. So lots of pats on the backs coming in here for people who've been attending. Again, somebody saying, I'd like to thank the Linn team for all the work they've done on the project. It's great to see the collaborative working having such a positive effect for children and their families. That's from Emma Nocton, who's a GM primary care in Galway. Maybe a question I haven't come to Dr. Howard, and I'm just wondering, Noel, is there something, I mean, you know, the link between GPs are carrying so much of what is expected, and indeed the move away from people going into the hospitals, being in the community, GPs are carrying a lot of that. Have you concerns about that, or is that working out okay in the context of the Linn project? Enough resources, enough support?
Excuse me, yeah. I suppose we're used to kind of everybody in the main. I know there are some access problems lately, but everybody usually has a GP. So we don't discharge people. We continue to hold them forever, really, ideally, cradle to grave. So we're used to holding patients. And if anything, this is an improvement because we have, Sláintecare and all the aspirations of Sláintecare mean that we will be able to access the appropriate services at time and then bring them back to us. And that's, I think, what this Linn project is aiming to do, that we can link in with Tinta and the wider team as needs be for brief episodic care and bring them back to us again, which is what we're comfortable doing, so and that might be a formal referral, or it might be that an informal piece of advice. And I would hope that over time we'll be able to kind of access the other members of the team as well, and their expertise. So no, there isn't any pushback from GPs about this. I think everybody feels it's a positive. I see some comments there about, kind of the differences between, CD&T and the care team and the Linn team, and I think that's something that we'll navigate as we go along. Certainly from my point of view, the more streamlined that is, that we kind of identify pathways and streams, and it's clearer, and maybe, I think there'll have to be collaboration between CD&T and Linn and the primary care teams to see where different children fit. And the easier that is for us to access, the better it'll be. No short answer, no concerns from our end. This is an excellent project, and the more continues, the better.
Great. And some of those issues you raised may be communications issues rather than blocks or barriers. Final question here. Would you have any advice for primary care teams who don't have this dedicated aspect of their service at present, but they're working with the same profile of children and young people? Any advice as to how we could provide an MDT approach within the current setup and constraints of primary care, i.e. disciplines not co-located, differing waiting times? So this person's looking for the answer to the wider problem. Any piece of advice, any of you who've been working in this new manner, something that could be transferred out to those who don't yet have this model available to them? Catherine, you've been leading the project, something that you're seeing could help.
Yeah, so I think what has really helped us, and I'm looking at Dr. Marianne there as well, is actually a bit like what we do. We have focused very much on setting up primary care team meetings for adults, and they're very well established. And I suppose setting up that primary care team meeting for children, I feel, has allowed, everybody working with children in primary care, so our senior medical officers, our nurses, health and social care professions, all of us to come together. And even that, I suppose, starting that discussion around children has been really valuable. Even, before we were able to offer this pathway of care, I think that has been very valuable. And I suppose what we'd hear from Marianne and colleagues is for them, it's made it easier just even to go somewhere and try and figure out, is there anything we can offer to these children and families. And I suppose we have been doing that a little bit informally in Galway prior to getting this project. We ran another project several years ago that was extremely successful, and it was with existing staff dedicating a piece of their time to MDT working. We didn't receive any additional resources at the time, but we had really good buy-in from our heads of discipline, and it meant that we saw children children who looked like they needed to go at the time, the early intervention service. We offered them a very timely appointment, and at least then those children were guided towards the service that was most appropriate for them. So I definitely think thinking, the way we think a bit about adults and older people, trying to, if you like, transport that into the children's services, because, Sláintecare at the outset, the focus was a lot on developing services for adults and older people. And I suppose we're very grateful that, some of the attention is now being shifted to developing kind of a primary care model for children.
Yeah, for sure. That's a great answer, and I think helpful. In fact, someone has just put in, this is great. I work as a primary care SLT, and this is exactly what we're saying we need. Would be lovely to have this rolled out. So very positive feedback from all of our attendees here today. And I think the conversation has been really enriched by people sending in their questions and comments, and people wanting to hear more about what really is such a successful project. I want to thank all of you here today for coming. I want to thank all of our participants. As we close, I want to thank Rosalind Harlan from the department, who does all the heavy lifting on the preparation for this. I also want to thank Tom, who does our technical work. The video of this will be available on the Sláintecare website. So for those colleagues who wanted to come but couldn't, or something happened, or other colleagues that you'd like to share it with, it will be there and it will be available. So do tell people they can watch it back, recommend it to your colleagues, and it will be available on the website. So from me to you, thank you to all my wonderful guests, and the really brilliant work you're doing is so impressive, so impressive. I look forward to seeing the evaluation, and I look forward to seeing it mainstreamed after the evaluation. It so deserves it, and our children really deserve it. Thank you so much. From me, Gráinne Healy, thank you for joining us, and continue to stay safe. Thanks, everybody.